we have to centralize. Yeah, we have to centralize, and it is not easy in centralizing, because you need to actually identify which villages, which districts are near to a clinic which provide maternal and child health services. Yeah, for example, in Tutong, probably only one clinic that is open. Yeah, in Kuala Belait, in terms of our countries. Similarly, in across the world, also the same. What happened was, the challenge was really bad and really large, and it really impact them. Now my screen is frozen. Is everyone still with me here?
Yes, Dr. Khadija, we can still see your screen and your voice.
I have to do it again because it's frozen. Okay. Now, the mothers and children are not getting the care that they need. They have to be selected. Yeah. For example, the vaccination for the different vaccination. I'm not talking about the COVID-19 vaccine, but the immunization. The immunization program has undergone certain impact as well all over the world. For some conditions, for example, in country like African nation, the effect of terminating or restricting the access to maternal and child health service has been life-threatening. Yeah, because in other countries, the maternal and child health service also give services to cancer and palliative, chronic conditions and acute conditions, unlike the situation in our country in Brunei. So it can be life-threatening, you know, when you can't attend care for the cancer patient, cancer children. So it is very frustrating. So the decline in the maternal and child health services is affected in most countries. Yeah. So despite the efforts to mitigate the disruptions, it never come back to the normal. Okay, if you can understand what I mean, if we have 100% of, if the mark is 100% for the quality of maternal and child health service that we have given before COVID-19, and then when COVID-19 occurs, we have to restrict and reduce the services. And when we were recovering from the different phases, we wanted to mitigate it again, so it will never come back to the 100%. It's still disrupted. Yeah. So whatever we have done before will not go back to the normal situation after COVID-19 has recovered. If it will come back, it will take a lot of time. Yeah. Right, so the pandemic has put ability to deliver health services, including the maternal and child health services, under additional pressure. Why? Because we are the center, you know, primary health center is the center of health service delivery in many health systems. Yeah, because we are the primary, that's why it is called primary, the first line of care for those women and children. Yeah. So maintaining a balance between mounting and effective COVID-19 response and ensuring continuity of health service has been challenging. Okay, because why? Those people, when we reduce the services, we reduce, for example, from 10 to 5. So those 5 that we don't use anymore, the staff has been deployed to COVID-19 areas. So it is very hard working for those people who are not who still have to continue with maternal and child health service. So they have to follow the SOP, prevent infection from occurring, give training for mask training, PPE, and as well as lack of staff. Yeah, lack of staff because of you have now, if 1,000 people has been catered to 10 clinics previously, then it has to be reduced by 5. So those 1,000 will be catered by 5 clinics. So imagine, yeah, imagine how those reduction in the maternal and child health service has imposed a burnout and stress to the healthcare system. Right. So, but what most interested was the digital health. During the COVID-19 era, digital health was seen to play a major role as part of the mitigation solution. Yeah. People use computer, people use online, telemedicine, digital health, using WhatsApp group or WeChat group, using the telephone platform. Yeah. So it can be part of the solution, but some services need to continue to be provided in person, even during the pandemic. So it is very difficult. We want to reduce the physical contact, but also at the same time, there are some needs for face-to-face interaction. Okay, so in-person care is still needed somewhere in the provision of the maternal and child health services. So there is a strong need to shape resilience in the maternal and child health services in preparing for and effectively responding to crisis. So meaning, now all over the world, we are already affected by COVID-19. We are already facing the high, the up, the down, and now I believe most of the countries are facing with the endemic phase, and because of that, there is a surge of number of cases of COVID-19 because of the allowance to be in the normal life, which we call the new normal. So sticking into the new normal, especially strengthening the standard operation procedure is not easy. Yeah, it is not easy, because even if you say you cannot hold function more than 30 people, you cannot hold function more than 300 people, people will still do, because who knows? Only the population knows. So that's why it is very important for us, if we want to see resilience in the healthcare services, including maternal and child health, there need to be a partnership between the healthcare systems and the population. So strengthening the healthcare system, including the maternal and child health service, is required. Otherwise, we will not achieve the sustainable development goals. So as you can see here, there are 17 goals. So I'll just point out those related to COVID-19. The first one is good health. So how can we achieve healthy life and promote the well-being for all at all ages? For example, in maternal and child health services for the woman and the children. How? When we reduce the service, that's mean we are going to capture a ratio between nurses and healthcare workers to a bigger population of women and children. Secondly, quality education. How are we going to educate the woman and children by promoting lifelong learning opportunities for all? For example, we are now embarking to digital health. How are we going to make sure that this is going to be effective? Next one is gender equality. How do we ensure that the woman and the children will achieve gender equality during this COVID-19 period and post-pandemic? The next one, reduce the inequalities. So inequalities in such a way that if we take this as an example, if we provide online healthcare services, how about those staying in the remote area? How about those people who cannot afford to buy internet access? So how are we going to address the inequality? Next one, peace and justice. How are we going to provide inclusive institution at all level for all the population, including the women and the children? How? How are we going to give them the care, the healthcare system, in the healthcare system? How are we going to educate them? How are we going to make sure that their care is still being maintained? So it is very important in the goal number 17, which is partnerships. So all the care that is provided through the maternal and child health services can only be strengthened through partnership. So we need to always involve the woman and the children in designing their care. What are the things that we can do? What are the things that we can't do? What are their limitations? What are our limitations? Things like that. All right, so let's reflect back. Reflection before we move to the new normal. Was our healthcare system, including the maternal and child health services, pandemic ready? Are we technologically illiterate? Not only the healthcare system, not only the patient, but also the healthcare workers. I believe there are also incidents by which nurses or healthcare workers who do not know how to even use technology for giving care. And as I mentioned earlier, the infrastructure. Some people are in the remote area. How can we reach them? If they are in the remote area, if there are no technology in that area, how are we going to give care to them? So we can't just simply say mHealth, digital health. It is unfair for them. Yeah. And again, can they afford to pay? Because technology means money. You have to spend money, you have to buy computer, or you have to buy phone, which is technologically ready. Yeah. So the infrastructure need to be strong rather than weak. Because if not, it causes anxiety and stress to the population, not only to the healthcare system, but also to the population. Right. So another thing is the impact of COVID-19 to nursing, midwifery, and public health education. Those nurses, those midwives, those public health sciences students, when they graduated, they are going to serve the maternal and child health services, the primary healthcare services. But are they prepared to face the pandemics, the COVID-19 pandemics? So when we look at our curriculum, for example, in Brunei, we are not sure that whether we are actually pandemic ready, because our emphasis was actually mostly on the non-communicable diseases. Yeah, for example, we focus a lot of attention on heart diseases, the obesity. So when COVID-19 occurs, we were panicked. Like, how are we going to teach the students on the COVID-19 if our curriculum were not ready then? So moving forward, what's next? So are we embarking on online, digital, electronic, even mobile information technology embedded in the healthcare system? Are we going to embed this in the healthcare system? Okay, I know that, for example, during the COVID-19, we can't do the home visit. So we have to call the woman, like, how are you today? Today is your 5th day postnatal. How are you feeling? Is your baby okay? Is your baby healthy? So you can't see what happened to the baby. You can't see what happened to the mama. All you can do is just listen to what happened to them and their progress. Yeah. So how are we going to make sure this is one of the way to address the limitation, but how are we going to make sure that the care that we are giving is inclusive, that we do not miss any important aspect of care when, as compared to when we do the one-to-one or in-person home visit to the home of the woman. Next, are the staff prepared to work during and beyond COVID-19 pandemic and during the endemic phase? Do they have the appropriate and adequate skills? Do we have to do ad hoc training? Are they clinically prepared? So most of the worry is wearing the PPE, having to wear the PPE during long hours. If you are working from 8 to 5, you have to wear those PPE. When are you going to change it? How frequent you are going to change it? And recent research have shown that frontline workers are actually suffering from heat heat stress because they're wearing the PPE. So again, the importance of mental health preparedness is very, very crucial. So we can do analysis by using TAUS or SWOT. What are our strengths? What are our weaknesses? How are we going to look into our strengths so that it cannot become a threat and it can always become an opportunities? Similarly, how we can convert our weakness to be an opportunity for improvement and so forth. Yeah. We need to review and evaluate the maternal and child health services, embark into innovation. How are we going to embark into it? We cannot just blindly go to the digital era. And again, most important is psychological support must always be there for the patients, for the woman, for the children, for the healthcare workers. So we need to thank you all the essential workers because they are the backbone of our community. Yeah, it is very, very crucial. Even if they are grocery workers, they also sell us food. Yeah, so this is only selingan advertisement. So I think that's all from me. Thank you very much. We can further discuss about what happened in the maternal and child health services. It is not a matter of how are we going to plan our maternal and child health services beyond pandemic, because we are already beyond pandemic. COVID-19 has already been there since the year 2019 and the end of year 2019. Now it's already 2022. We have been experiencing where is the high surge of COVID-19 infections. We are now actually moving beyond. We are in the endemic phases. It's not anymore about planning, but how are we going to sustain and making sure that our system is resilient. Yeah. Because you can always call for care, but are your questions consistent? Are everything being asked? You don't miss anything. Yeah, so these are some of the things that we can think about. Thank you very much again for the invitation, and I hope I have shared very good points with everyone. If you have questions later on, we can have a question and answer session. Thank you so much, everyone. Tasha, I give the session back to you.
Okay, thank you so much, Dr. Khadijah, for the session. It's very interesting. And as well, I see from your presentation that it's quite similar from your country, Brunei and Indonesia, the condition where at the very first of the pandemic, it's really hard. The people, the patients, and also the health workers as well is reluctant. They're scared to see each other, so it's hard for us to deliver the health system, etc. And it's really important for us to know what to do. And it's not only about it's a really good thing because we're in Indonesia juga working on the telemedicine or the digital health, but we need to see how about those people that living in the remote area. Are they going to have the same as we are here in a rural area or what, like that? All right. Thank you very much, Dr. Khadijah. Maybe we will see you again at the Q&A session after this, Dr. Khadijah, to answer all the questions. All right. Okay, now we're moving on to the next session. The second session is, The second session is, now we're moving on to the second session is from Ms. Vibhuti as our second speaker to present and deliver the topic about primary healthcare roles in promoting the health of tribal populations. Okay. Hello, Ms. Vibhuti. How are you today?
Hi, Ms. Elizabeth Tasha. How are you? And thanks for inviting me for the topic.
I feel super excited to meet all of you. To be honest. Oh my God. All right. Maybe before you present your presentation about the primary healthcare roles in promoting the health of tribal population, I would like to give a little introduction, a little bit background of your of you as our second speaker. All right, let me share my share screen. Wait. Okay. Okay, so this is a little bit background of Miss Kumari Vibhuti Nayak. So Miss Vibhuti as is assistant professor, social anthropology, Center for Studies in Social Sciences, Calcutta. And this is some of the research project that Miss Vibhuti have done, as you can see here. There are some of them, and this is the research interest of Ms. Vibhuti. There are tribal health, intersectionality and health, social and cultural, determinants of health, adolescents' health and health-seeking behavior, and gender-based violence. And also, this is some of the publications or journal articles that Ms. Vibhuti Nayak have joined or created with other people. And yep, I think that's all a little bit introduction of Miss Vibhuti. Okay, now without any further ado, I'll just give it to you, and time and screen is yours, Miss Vibhuti.
Okay, thanks, Ms. Elizabeth Tasha, for such a great introduction, and I'm delighted to here to share my work. I'm screen sharing my. Is it visible to all?
Yes, it's visible, Miss.
My screen is okay. Okay. So, very good morning to everyone, and it is a great pleasure to be the part of the health system course on the primary healthcare management. So, today I'm going to share my research work on the primary healthcare roles in promoting the health of the tribal population. But before sharing, let me introduce about the word first, the tribe or the ethnic group. So tribals in India are also known as the indigenous, native, ethnic, and the First Nation and the Aboriginal across the countries. In Indonesia, I assume that the tribes are recognized as the ethnic group, and there are approximately more than 1,300 recognized ethnic groups. Likewise, in India, there are notified tribal groups over 700, and tribes in India generally are assumed and denoted as as an aggregate of the people living in the primitive condition. During the colonial period, when the scholars who were doing research among the tribal in their respective writings have used these terms synonymously. For example, Riesler and Martin used the tribe as the Aboriginals, Hutton used it as the primitive people, and wherein Alvin has used the Indian tribe as the original owners of the country. Hence, tribe got a different name across the state and across the countries also, and has been used differently in various parts of the country. However, coming back to the concentration of the tribal population in India, this is the geographical map of India in which you can see that the eastern part of the India is the highly concentration of the tribal population as compared to the south, north, and the west. Still, India is considered to be the second largest tribal population with regards to the tribal population in the world after Africa. However, most of the tribal people are observed to be the vulnerable because they are being marginalized. They live in the poverty. Their location or the residence of the home is in the remote area, and they struggle for the resource-based livelihood at the present scenario. Discussing more about the tribal population, especially those who have become the minority population in their own lands, have suffered comparatively the various patterns of the diseases. In 18th and the 19th century, these indigenous people has suffered as well as disseminated by the infectious disease such as the typhoid, fever, tuberculosis, and influenza. But in the mid of the 20th century, following the near universal experiences of the urbanization in 1950, other health risks also emerged. While communicable disease continue to affect continue to affect the larger indigenous population around the world. In India, vulnerability to the injury, alcohol misuse and drug misuse, kidney kidney disease and other became the modern indigenous health hazards. Because indigenous health hazards, and because of this, living in the remote areas, they have faced various problems like land alienation, the education, health, displacement, rehabilitation, and issues of environmental degradation. But among all these things, the health was considered the most important by the government of India. Um, because as compared to the non-tribal community, the life expectancy is significantly lower, and the incidences of the most of the disease became higher. So to explain about the health determinants, which was grouped into certain forms. Firstly, it was by the research scholar, it was noted that the genetic predisposition, in which the diabetes, alcohol disorder, and cancer was noted, but it was noted to be less significant among the tribal population. But another significant disadvantage was that they were being into the socio-economically disadvantageous scenario, in which the poor housing, low education, unemployment, and inadequate income was noted, which has the larger implications on the tribal health. Uh, Next, coming on to the natural resources which they were dependent on by the development projects that was going into the favor of the tribal population, just like the education, health, and other mining industries were set up. These also took a toll on them with regards to their health. And lastly, it was noted that there was a link between the colonization and the poor health also, in which the loss of the sovereignty along with the disposition was noted, which created a spiritual operations with the increased susceptibility to the diseases. So overall, clubbing with all these things, uh, social determinant of health as a concept became a booming topic and became a research area, that what are the determinants of the health that became in the context of the tribal population, that became more for deteriorating the tribal health, in which first of all was the access to the healthcare services, where the tribal people, those who were living in the remote area, were able to access the healthcare centers or not. It was a very big question mark in the earlier phase. Next was that they were exposed to the crime, violence, and the social order just because of the development projects there was going on, and they were connecting with the mainstream population. So there were different types of the violences going on. The crime was happening, which was related to the socio-economic condition also. The third point is the social norms and the attitude. There are, because of the cultural beliefs and the norms and the tradition which the tribal people were falling into, was not matching with the mainstream population. So this differences also created a toll on their health, mainly with regards to their mental health. Uh, they had limited access or the exposure to the mass media and the emerging technology, the tribal people. So they were not proactively participating into the mass media, and whatever the media was projecting them was not favorable to these people. Uh, Here the second the transportation option, the people, the tribal people, those who were living into the remote area, they were finding difficulty to reach the healthcare service center, because the transportation was a major issue. They didn't have their own vehicles or the public transport, as some of the people were living into the hilly areas, and they were unable to communicate the health centers. Then again, availability of resources to meet the daily needs. Even for their basic need, they have to come to the city area, and they have to they still lost their wages when they have to purchase a little bit of the things for their meeting the daily needs. Public safety also became one of the major issue while they were communicating from one place to the another place. Their standard of living as compared to the non-tribal people was considered to be the low, but their standard of living according to them was good enough, as they were residing in mostly into the forest areas. The support social support system was among the tribal community was found to be good, but again when it came to the to get the health services with regards to get into the hospital, at that time their social support was also found to be less. In case of the gender, if we see that female tribal were especially dependent on the male to just go to visit to the hospital, they could not go alone and have a pay visit for their health issues. And because of their ethnic identity, uh, they they were seen different. They were distinguished as a different group when they come in with the mainstream population. Even the cultural beliefs, traditions, and the norms which they practices in their routine life, which was different. So all these determinant of health clubbed up together and made the tribal people health in the deterioration phase. But here at this time, the role of the primary health care came into, and despite of all the social determinant of health, the primary healthcare system, they raised awareness among the tribal population, and it was the first step towards improving the health outcomes. These primary healthcare centers are frequently conducted the information, education, and communication by the various means in which the camps were set up, and they stressed upon giving the importance to the simple routine life in which the hand wash, regular antenatal checkups, institutional delivery, and immunization was taken care. Through though this had a little earlier, it has the little impact, but they had markedly improved the content and the quality of the health messages that targeted at the specific tribal groups through the appropriate means. For instance, in Rajasthan, the health messages was commonly imparted through the dancers, folk musicians, puppets that appeal to the tribal population. In other parts of the India, the posters, hoarding, bus boards, personalized letters, radio jingles, and video broadcast were featuring, in which the popular stars were found to be the effective means for imparting the health messages among these communities. Even a team of the health communicator are also contacted to convey the key health messages through sustained interaction in the schools of the tribal area. Their workshop were in the workplace and the community. Even various health care programs were also introduced for the school children's, for the women and for the men also, which covered the tribal region belt. Second is the bringing the health services to the remote area. Earlier, the initiation of the medical camps were initiated, but later on, the mobile medical camps was came into the picture, in which the mobile healthcare team consists of the doctors, two nurses staff, a lab technician, male and female support staffs were introduced. in the mobile health camp, the vehicles are also equipped with the oxygen cylinder. The emergency drugs were also being provided, and there was plenty of the information was given to the tribal population. Even the medical staffs with the on the common illness, first aid, maternal and child care services with the family planning were there, so that if anybody from the village or the community come to approach them, so they could give the messages to them. Additionally, some of the health services with regard to the specific health issues like AIDS, malaria were outsourced by the non-governmental organization. Just now, means like during the COVID times, these primary healthcare centers played an important role in passing on the information how to take care during the COVID times, and still the people are practicing all these things, and they are keeping well uh, well in their own areas. Next is like door-to-door visit, door-to-door accredited social health activists, which is known as ASHA, and auxiliary nurse midwives, ANM. These are called the sisters in the tribal areas. They were actively participating in gathering the information from the primary healthcare centers and passing it to the tribal people. They were given, these ASHA workers and ANM were given special type of the training in which the government health schemes were introduced to the tribal people, and so that they could make understand the people that why these health policies or the programs are important to them. So along with that, a range of the free medical services was widened to include, which included the pediatric, gynecological, and the general medicine services in the complex cases. Additionally, free immunization, basic lab test, free medicine for the full course of the treatment was provided. Most importantly, the doctors from the city pay visit to these remote areas of the people, and which brought a rotational, which was brought on the rotational biases, and the higher health facilities are still to be promised in the setup for the remote areas. During the emergency transport was also provided. Am I clear? Because okay, yeah, emergency transportation system was provided to the expected mother, those who were in the during the delivery time, with the partnership of the public-private partnership, and it is called the Mamta Vahan in India, where the expected mothers were taken care, means were taken from their home and admitted to the healthcare centers. Again, the employing the health workers from the tribal community. It was the tribal people were finding difficult to have a trust on the modern medical practitioners and the other modern healthcare team. So the primary healthcare centers, they started to initiation to involve the community people or the community female and the females, so that they can make their people understand what exactly Indian government want to implement the programs for, especially for the tribal, for their health benefits and for their improvement. In that, as especially the ASHA and the ANM were keep the bridge between the primary healthcare center and the tribal population, who made them understand about the programs and the policies that were beneficial beneficial for the tribal people. And along with that, some counseling were also done to the tribal people, so that the preventive and the promotive health behavior could be noted among the tribal population. Even as I earlier said, that doctors pay visit to the local or the remote areas to bring awareness about the health issues and promote the health behavior. So even the setting of the health desk at the primary healthcare center to address the complaints by mediating between the consumers and the service provided was again an initiation from the primary healthcare. The changing the behavior of the healthcare provider. Earlier, when the government programs, healthcare programs were implemented to the tribal population, earlier it was noted that the non-tribal people were found to be discriminating, and their behavior was insensitive to the tribal people. So now what the a training program is given to the healthcare provider team also, so that their behavior should be softened towards the tribal community, as because they were unable to understand some of the medical terms, or they were unable to communicate why what are the problems or the issues were there in the means why this health issues are happening. So to communicate in a better way, the changing behavior of healthcare provider was taken care by the government officials. And lastly, that primary healthcare centers, they provided the financial support also. In while setting up the camps, medical camps, which was going into the remote areas, these free medicines were provided to all the people, those who visited the camp, and along with that, free training programs were also introduced, in which one of the most adolescents reproductive and sexual health care, in which the female adolescent, those who were in between the 15 to the 24 years of age group, they were selected from the village group of the people, and they were made to understand what are the health practices at their own age, could be introduced into the daily life routine, so that they can get a better health, and in future they could not in future they could be the healthy person, and be good and healthy in their reproductive age. Even during their delivery time, the financial aid was provided. It's was near about like rupees 1400 when the delivery was happened at the hospitals. So all these things are being provided by the primary healthcare centers in India, and especially in the remote areas of the tribal. Next, coming coming into the that health services are, if we see all these things, that the primary health services are agreed upon the comprehensive health practices. Their accessibility is always to be noted, and acceptance by the tribal people has to be noted, and these all of these provided a scope for the community development among the tribal community, and there the special availability, and all these things are available at the cost of the community, which a tribal person can afford it. All these were taken care. This is this is the structure of the primary healthcare center in the tribal area, and the people and the organization involved in it, in which we can see that every 20,000 of the population there will be one primary healthcare center, and it will be included to MBBS doctors and other staffs, and other services will be given. ANM will be there. one of the nurse practitioners or the BSc community health, and one male will be there. Even the social worker will be also provided. This is one of the structure that is very common on the ground, which we see in the remote areas of the tribal in the tribal areas. And but most important is like the role of the ASHA and the ANM, those who pay regular visit into the tribal communities, those who go regularly into the tribal community, and they keep and register that which people means who is in which village, who is facing what type of the health problems. So they keep a tab, they keep a register, and they inform the primary healthcare centers, doctors, and other medical team that these people are facing such type of the problems, and you have to pay visit and do all the necessary things to for their betterment of the health. So this now what is happening is right now there the tribal people, those who have gained the information, and they are now becoming the part of the primary healthcare centers, and they are getting information, and these people are involving the tribal people, so that they could also they could learn from the primary healthcare center and give and implement into their own community and area. So health literacy is also involved in them, in the health literacy through their through means in the school some camps will be there. Through technology, now the technology is becoming a big challenge, because as we know, in the remote areas there is no internet is there, but it is not in a good condition or in the functioning, but still these things are taken care by the government, and they are in the future they are implementing it. And the mass media through various sources like radio, TV, and all these things, the health the information about the health with regards to various diseases are imparted in the tribal belt. And the folk art is one of the best one of the best among them, just because the folk art, the way the presentation is done, the way they depict in the folklore or on the songs or the stories behind it. So this give a big impact that how their health could be understood. With regards to that, again, the development programs and the social determinants are again taken care, which is helpful into their daily routine area. And the Gram Sabha is taking care. Gram Sabha is the village community in which the community participants are always being seen. So if we see the essentials element that has been covered by the public health care is like first of all is the medical care that should be given to the tribal population, which is much needed, and second is about the maternal and the child health, including the family planning. Most of the time the tribal women are focused when they are pregnant and when they are bearing the child, or when they are in the lactating phase. So when they are in these phase, at that time the government makes sure that they also start have a family planning, so that because of their socio-economic condition they don't get into the economic burden. Safe water and supply and the basic sanitation is made sure that people practices all these things in their area, so that their daily for the betterment of their health, and they don't fall into the any type of the infectious diseases. Their prevention and control of the locally endemic disease has been done, which has been now noted down during the COVID times, that how they could prevent themselves from the infectious, communicable infectious, and how they can control, in which public healthcare centers they have made an isolated space and even the tribal people have also their knowledge has been included during this period, and at that time with the help of both they were able the COVID situation was relatively less affected in these areas. Collection and reporting of the vital statistics, it was necessary just to keep the tab that what are the health issues that are faced by the tribal population. Education about the health, it is one of the another important function, because the health information was being passed mostly among the tribal children, so that they can bring into the practice into their home, and they can make their adult members also practice all these things. National Health Program, it is a worldwide, and it is done through the various campaigns, various other activities. Even the doctors and the other health practitioners go in, come and go into the remote areas, and they bring awareness with regards to various diseases, and their health should be improved. Referral services are there, training of the health assistant, local DICE, and the health workers. These are done during, especially for the pregnant ladies. If the pregnant ladies are unable to reach the healthcare centers, at that time these health workers, those who are within the reach for the pregnant ladies, so that they can assist on behalf of them rather than bringing into the hospitals. And basic laboratory services are provided to them. So now the ongoing primary healthcare programs, which includes which are now including the human resources for the tribal health. These human resources, I mean to say here, is that the inclusion of the tribal people and their involvement in the with the modern medical practitioners, that at least they should be understandable, should be understood for the minor health issues, what how they should be taken care, what should be the preventive health measures, what should be the curative health measures, and within their limited accessibility, how they could improve their own health. All these things are imparted and transferred to the to the tribal people, in which mostly the traditional healers and the tribal youth are included. Addressing the tribal health program, there are various health programs which are going on, which the tribal people are unknown about this. So through this, through the involvement of the tribal youth and the traditional healers, the various programs that has been made for the tribal people, in which their finances are low, all these things has been covered up, are being covered up by the primary healthcare centers. Now they are also want to integrate the traditional tribal medicine, because as we have noted that the modern medical practices, modern medical tablets and the other things can't be afforded by the tribal people in because of their low financial status. So they wanted to include that whatever the traditional practices they are having, or they are still going on, so they want to introduce all these things in their life, so within their budget they can afford all these things. And they also want to introduce the knowledge, research, and the data on the tribal health. So various people are now coming into all together, the non-tribal and the tribal community. So there would be the exchange of the knowledge, and their research also has to be done, that how more in a more way that improvement can be done, is especially for the tribal women, especially those who are facing the anemic problem and other health issues. Their mortality rate are high among these people. So all these different research are going on in this process. And lastly is the governance and the participation. As usual, that governance is like how the government is taking care of these people are mostly necessary, and earlier whatever the policies were made in or the programs or the welfare programs were being introduced in the tribal community, they lacked the input of the tribal people, how these and various failures has been also seen. So now to face the failures of the health programs, now the primary healthcare center along with the government, they are including the tribal people to take their input, and even most important thing, the basically the cultural beliefs and the tradition, because most of the things that are being introduced are not being were not being taken by the tribal people, because there was difference in the opinion and difference in the cultural beliefs, in which, for example, when the tribal people get the prescription from a doctor, then and he or she gave the course of the medicine. So in which the tribal people didn't take the course means like if it is taken by the 7 days or the 10 days, people used to drop, and people used to drop, didn't have the medicines after 2 or 3 days. They just see that only in the 2 days, if they get effective, means if they are good, then they dropped the later 5 days of the medicine course. So and various health issues has been occurred due to the medicine, such as they have the gas problem, or they begin to feel some type of the uh, ill health issues. Side effects of the medicine was also noted. So at that time they dropped the medicine also. All these things were not explained by the earlier doctors, but now all these are being explained by the doctors, and wanted to be explained by their own community members. So they are expecting the participation of the especially the tribal youth and the traditional healers, those whose words or whose voice could be listened and to be introduced. Thus, we can see that primary healthcare centers are the keystone for the tribal population, and they have been a vital role as the first level of the contact and the connection between the individual and the healthcare system. So the healthcare delivery so this brings the healthcare delivery as close as possible to promote, prevent, cure, and rehabilitate in the tribal areas. So this is it. Thank you.
All right, thank you so much, Ms. Vibhuti, for your presentation. It's really insightful talking about what is the tribe tribe population itself, and then you've talking to about the various problems that they are facing, and then you mentioned about the role of the primary healthcare, for example, to raise the awareness of health issues and bring health services to the remote areas. Something that I really interested is about the door-to-door visit of the accredited social health activist, or ASHA. Am I right?
Aisha.
Yeah, Asha, it's really interesting. I would like to get to know more about it. Maybe I will research about it. And then after that, you also mentioned about the health services that are agreed on. For example, it should be comprehensive and accessible and acceptable, many things. Yep, I think that's all for the second session. And I would like to also thank you to Ms. Vibhuti for sharing the session, and remind all the participants, if you have any questions for the first session, the second session so far, you could submit it to the Slido that we have sent the link on the comment of the Zoom. And also, if you want to ask your question directly, you can ask your question to use the raise hand features, but on the Q&A session after the third session finishes. I think that's all. Maybe we will continue to the third session. All right. Now, moving on to the next agenda is the third session. We have Ms. Alia Hasfi Arini as our third speaker to present and deliver the topic about what should we do better in providing maternity care during health emergency, and the lesson learned from maternity care provision during COVID-19 pandemic. Hello, good morning, Miss Alia. How are you today?
Hi, Tasha. How are you? Can you hear me?
Yes, I can hear you. You're audible.
Oh, very nice to meet you.
Okay, nice to meet you too, Miss. Maybe I would like to share a little bit background of Miss Alia. All right, let me do my share screen. Wait a second. All right. Okay. Can you can you see my screen?
Yep.
Okay, cool. So Miss Alia Hasfiarini is a research assistant in various public health projects in Indonesia for 5 years, experience in planning, monitoring, and evaluating health projects and conducting quantitative and qualitative research. And this is some of the experience that Miss Alia have achieved for currently is a research assistant at the Center of Health Equity, the University of Melbourne, and also the section editor part-time Indonesian Journal of Health Administration. And this is the other experience that Miss Alia have achieved. And the accomplishment, Miss Alia is Australia Award Indonesia awardee at the 2019 and Student Engagement Grant of the University of Melbourne recipient 2020. And the education is the University of Melbourne, Master of Public Health at 2021, and Airlangga University, Bachelor of Public Health at 2016. I think that's all a little bit introduction of Miss Alia. Without any further ado, I would like to have the time and screen is yours.
Thank you. Let me put up my slide. Yeah. Can everyone see my slide now? Okay, cool. Thank you for the introduction. And first, thank you so much, Ibu Erna, for inviting me today. And thank you to Dr. Hadiza and Associate Professor Vibhuti Nayak for that great presentation. My name is Ali Hasfiarini. I'm a research assistant at the Gender and Women's Health Unit, Center for Health Equity, Melbourne School of Population and Global Health, the University of Melbourne. Sorry for the long affiliation, but should be mentioned. Yes, I did my bachelor degree at the Faculty of Public Health, Airlangga University, and I graduated in 2016. And in 2019, I continued to my master's study at the University of Melbourne. As part of my study, I did research on the impact of COVID-19 pandemic on the provision of maternal care in Indonesia, and that's what I'm going to talk about for the next 20 minutes. What should we do better in providing maternal care during health emergency? Lesson learned from maternal care provision during the COVID-19 pandemic. Before I did my research, I did a literature review first, and here is what I found. That first, women have a right to continue to receive high-quality maternal care during the COVID-19 pandemic. However, the COVID pandemic has resulted in many changes in the provision of maternal care around the world. For example, we moved the face-to-face consultation to online consultation, and there's also reduced timing and frequency of antenatal or postnatal care visits. Other than the changes in the provision of maternal care, some research also found that the health workers had overwhelming experiences while working during the COVID-19 pandemic. For example, they experienced increased workloads because their colleagues got COVID-19, so they had to cover for their colleagues' job, and also they work outside of their usual scope of practice. For example, midwives, before the pandemic, they only responsible for providing maternal care, but during the pandemic, they had to also work, for example, at the quarantine facilities. And there were also reports that the health workers got fears of getting COVID-19, and due to the limited of protection equipment, it increased their fears of getting the COVID-19. And based on the literature review, I found that there is a little information on how the COVID-19 pandemic impacted on the provision of maternal care in low and middle income countries, specifically in Indonesia. That's the reason I decided to focus on this study. Okay, before I talk about how I did my study and the findings, I think it is worth to mention about quality of care. So here's the WHO Quality of Care Framework for Maternal and Newborn Health. So to ensure that we're on the same page, what I mean by equality of care. So this based on this framework, the quality of care has two domains. The first one is provision of care, and the second one is experience of care. So based on the provision of care dimension, it's more like focus on like adequate facilities, adequate health equipment or health workers. So in order to be considered as having a high quality of care, you should have adequate number of health workers, health equipment, or health infrastructure. Well, based on the experience of care domain, based on this domain, women are expected to receive high quality care if they have like effective communication with their health workers, receive care with respect and dignity, and also have adequate support from their families or even from the health workers. So this is the quality of care that I'm referring to when I'm talking about quality of care in the next slides. Sorry. Yep, okay. This is how I did my study. So I had two research questions. The first one is how has COVID-19 influenced the provision of maternity care in Indonesia? And this research question more focused on the health system, while the second question is about Indonesian midwife experiences in providing maternity care during COVID-19 pandemic. This research question more focused on the midwife experience working during the COVID-19 pandemic. So my study based on the midwife's perspective. This is because midwives are the backbone of the provision of maternity care in Indonesia. Then my participants are more midwives working at the primary health centers and village health posts. I didn't cover health workers or midwife working at the hospital. I did the study in two study sites, Surabaya and Mataram. That's because at that time, Surabaya was the cities with Surabaya has the highest number of COVID-19 cases in Indonesia, while Mataram had much less COVID-19 cases, and we want to compare the findings between these two study sites. My study is qualitative study. So I did online interview using WhatsApp with the 15 midwives. And after collecting the data, I did inductive thematic analysis for analyzing the qualitative data. So here is what I found through the data collection. So in this diagram showing the changes in the provision of maternity care based on the interviews. So after the data collection, my co-authors and we mapped the findings into the COMBI model of behavior. So COMBI is capability, opportunity, motivation, behavior model. We map it whether the changes facilitate the provision of high quality maternity care during the COVID-19 pandemic, or it actually served as a barrier for the provision of maternity care. As we can see here, we got a lot of changes during the data collection, but due to the limited time, I would like to focus only on the main changes during the COVID-19 pandemic. Okay, so the COVID-19 pandemic has resulted in great changes in the provision of maternity care in the two study sites. The first one is changes in the location of maternity care. So before the pandemic, both in Surabaya and Mataram, the maternity care were available at primary health center and also at the village health post. But during the COVID-19 pandemic, in Surabaya, for example, all of the participants said that the maternity care is centralized at the primary health center. While in Mataram, we had a mixed response, like some of midwives said that they still provide care at primary health center and village health posts, while the others said that they only provide care at primary health center only. The next one is reduced number of in-person visits. And this is actually in line with the WHO guideline and also the Indonesian Ministry of Health guideline that to prevent the COVID-19 transmission, we should limit our face-to-face meetings. So midwives reduce the number of consultation face-to-face, like antenatal or postpartum. But actually, the WHO also suggested that to provide telehealth consultation or online consultation to replace the reduced number of in-person visits. However, what I found during my study is that some midwives reduce the number of in-person visits, but they do not provide regular telehealth consultation to women. The next one is postponed or canceled maternity care. So women are expected required to do consultation with general practitioner or doctor in their first and the third trimester of pregnancy to screen their pregnancy or childbirth risk. But due to the reduced number of in-person visits, midwives said that some women are reported to cancel or postpone their consultation with the GP or with the doctor. Next one is reduced number of companions. The companions are people who accompany women during the maternity care. It could be during the antenatal, labor, birth, or postpartum care. And the companions could be doula. It could be with the family members, for example, mothers, sister, or husband. Before the pandemic, women were allowed to be accompanied by their husband during the antenatal care visit. But during the, that's before the pandemic, but during the pandemic, some midwives reported that they didn't allow women to be accompanied by their husband at the antenatal care visit because they want to maintain the physical distancing at the consultation room. The number of companions also reduced during labor and birth to one or even like no companions at all. Okay, so what I found is not only negative changes on the profession of maternity care, but we also find some positive changes. The first one is the availability of an appointment system. So the appointment system is purely like a midwife's initiative to continue to provide safe and adequate maternity care for women. It's not stated on the WHO or in the Indonesian guideline. Here is how the midwives wanted to protect women so that they will not get a COVID-19 because of the overcrowding maternity care facilities. The next one is availability of maternity care for women suspected or confirmed with COVID-19. So this is really support for women to continue to get maternity care despite of their COVID-19 situation. This is because in Ethiopia, there's one study reported that there was a stigma towards women suspected or confirmed with COVID-19. Then that having that stigma refrained women from accessing the maternity care. So women feel uncomfortable, feeling afraid to come or visit the maternity care because of the stigma. The next one is strategies to reduce the COVID-19 transmission. I found that in each of health facilities, they have their own strategies. For example, like installing the protective barriers at the consultation room, reducing the number of visitors, and also the important one is doing COVID-19 screening for pregnant women. It is to ensure that all the healthy pregnant women were treated at the primary health center or village health post. But for women who get tested positive, they were referred to a hospital. Okay, next one is the findings on the midwife experiences. Similar to other research, and I think it's also similar to what Dr. Khadijah said previously, that the midwives in this study also experienced formidable challenges in providing the maternity care during the COVID-19 pandemic. Here's the themes that I've discovered through the data analysis. That first, the midwives have a great concern on their personal and family well-being and safety because they had to continue to work during the COVID-19 pandemic. So they got fear of transmitting the virus to their family members. And this is also because the participants reported that they had a limited protection from the higher authority for their safety and well-being. Midwives also reported they experienced increased workloads because their colleagues got tested positive and they had to cover for their colleagues' job. So what do these findings mean for Indonesia and elsewhere? First, maintaining high quality of maternity care is essential. This is because we have seen that the COVID-19 pandemic or the health emergency has resulted in many changes, and some changes might lead to inadequate maternity care for women. For example, the irregular telehealth consultation while the number of in-person visits were reduced and the postponed or canceled maternity care. It means that some women didn't get care that should have got during the COVID-19 pandemic. In maintaining the quality of maternity care, we should take into account the women. Okay. In maintaining the quality of maternity care, we should take into account women's experiences of care. So during the emergency, our focus is not only on like the availability of health facilities or adequate number of health workers, but we should think about, we should consider that women continue to receive a positive experience of care during their maternity care visits. For example, what we can do is like allowing women to be accompanied, to have companions during their maternity care, so they will not get feeling isolated, or is also to prevent mistreatment during birth. So mistreatment is one of types that could lead to negative experiences of care, and there are many types of mistreatment. For example, physical and verbal abuse, stigma that I've mentioned previously, discrimination, abandonment, lack of informed consent, loss of women's autonomy, and lack of supportive care. The next one is we should like incorporate social patterns like socioeconomic, race, culture, etc., into the development of guideline or regulation policy to ensure that we have equal access to high quality of maternity care. As we know that the pandemic is not only impacted on not on the health sector, but also on the economic sector, it means that some women or their family members have lost their job or have reduced income, and this might affect them on accessing the maternity care. It could limit them to access the maternity care, the medicine, or even like transportation to get to the health facilities. And another example, I think, is also been mentioned with Dr. Hadiza already mentioned this, but the telehealth consultation or the online consultation, it is a very needed innovation during the COVID-19 pandemic because we have to limit our face-to-face meetings. So we moved the face-to-face consultation to online consultation. But how about women who are living in a very low socioeconomic status or living in a very rural area? This might be not relevant to some women in the two study site in Surabaya and Mataram, because Surabaya and Mataram considered as urban area. But how about women living in, for example, eastern part of Indonesia? How will they access the services? I mean, like the number of face-to-face meeting is reduced and move it and replaced with telehealth or online consultation. But how about that women, like whether it's not unclear if they got access to the phone or internet. So that should be considered in developing a guideline on how to provide maternity care during health emergency in the future. And the last one is health workers is a key. Provision of any healthcare can't be done without health workers. In terms of maternity care in Indonesia, midwives are the backbone of the provision of maternity care. So their health and well-being should be protected to ensure that they could continue to provide maternity care during the health emergency. Here is some references. If you are interested to read more about the mistreatment, about the WHO framework, or about my research findings, you can check these articles. Thank you, and happy to take any questions.
All right, thank you so much, Ms. Alia, for sharing your presentations. Now, maybe we're moving on to the Q&A sessions that we have listened from Dr. Khadiza, Ms. Vibhuti, and Ms. Alia. Therefore, all the participants who are present, whether in the Zoom meeting or maybe in the YouTube channel, you can write your questions in the comments column, or maybe you just submit it into the Slido. Or you can just use the raise hand features to ask your questions directly. Okay. Okay, maybe since nobody we have no person to ask the questions directly, I have a few questions in the Slido. I will read it for you. Wait. Okay. Okay. So the first question is from Mr. Rafi Abiyu for Dr. Khadijah. The question is, how was the condition of MCH services before and after the pandemic in remote areas? Then what concrete steps are being taken by the government? Thank you. To Dr. Khadijah, time is yours.
Thank you very much for your question. That is very interesting questions. So that's actually stimulate our brain not only to think about the remote area during the COVID-19, but also before and beyond. So in Brunei, we provide the flying services to the remote area. Those people in the remote got to be visited at least once in a week or once in every 2 weeks fortnightly. So they are being visited. But the thing is, before COVID, those care will be given, when you want the remote area, you will make an announcement that we're going to come, and then who required the care for the healthcare workers from the healthcare workers, they will need to be at the an area, a place where you gather together. So with the COVID-19, it is very difficult to do that, because if you come over and then people will gather together, and then you are actually encouraging the transmission and infection of COVID-19 to others. So I'm not quite sure how they control it, but I still saw people from the maternal and child health service and also primary healthcare. They still do the flying service. Perhaps Matron Hajah Ramla, if she is in, she can share here. Or Hajah Liza, are you there? If you can, whether the provision of care is still been done to the remote area during the COVID-19 time. I don't got any help from Brunei people here. Anyway, right. So what happened is during the COVID-19 time, the visit is still been done. But rather than gathering together in Balai Raya or in a place where we can give care at one time, we have SOP that we need to be strict with. And I think, Lydia, is it going to the home rather than using Balai Raya or a big hall? So I'm sure that they do with the SOP, and rather than going to the big hall, they go to the house or clinic, maternal and child health clinic with strict, rather than just saying everyone can come because we are coming. But this time it's like whoever wanted to be having the care to be provided to them, they need to make an appointment. Perhaps Alia also can share a situation in Indonesia. How was it, Alia, during the COVID-19 pandemic? How do we tackle, because I know that in also the telehealth, telemedicine, and the flying, the service to the remote area. How do you deal with that during the COVID-19? I would like to learn from Indonesia as well.
Well, thank you, Dr. Hadiza. My research is not really covering the remote area, but what I can share with you is that during the COVID-19 pandemic, especially on the first wave, like all the village health posts were closed.
Yes, we can hear you.
Okay,
Can you mute your microphone? We can hear you.
Okay, so like during the first wave of the COVID-19 pandemic, the village health posts were closed, so that it made like quite challenges for the health workers, especially who usually come door to door to the pregnant women. But like I think, because that what I found is that telehealth consultation is not really available for all. Like they reduced the face-to-face consultation, but the midwives didn't really provide the regular telehealth consultation. It means that perhaps like the women in the rural area, they didn't get a chance to check their pregnancy because the village health posts were closed and they do not have the telehealth consultation, which is very sad. Yeah, but I'm not really sure. I think the condition is improving now because like we already is some restriction, and I think since early last year that the village hospitals were reopened. So hopefully everything's getting back together. But the key is like to continue provide care, the maternity care, which is safe for women and also safe for the health workers. We don't want like the pregnant women coming to the maternity care to get their pregnancy check, but after that they got tested positive, or even the health workers getting tested positive. That's very bad. I mean, like health workers should be healthy to continue provide the care.
With sorry, Tasha, we are having our Alia.
It's okay. It's okay.
Yeah, the thing about the thing about having to live with COVID is that you never, because one day when you wanted to admit a person, probably a pregnant woman or people who wanted to give birth, before they are being admitted to the for labor, they are being tested for PCR, then they are negative. But then the next, probably they are positive. So it's very difficult because one day you might be negative, the next day you might be positive. So relying on PCR and relying on the ART test, both are very confusing. So again, coming back to the question just now, what happened to the provision of maternity MCH during the prior and after the COVID-19 pandemic in the remote area? We do visit the remote area using service, but previously we just allowed anybody who wanted to have the service to come over, so that we don't have to come back, or we don't miss anyone who wanted the service. But this time, because of COVID-19, we have to actually give them a strict appointment. They only come if they have appointment. If they don't have an appointment, we may wanted to consider for them to adhere to the strict operation procedure, especially prevention of close, physical distancing, and as well as wearing the mask. Yep. I hope I've answered the question.
Okay, thank you so much, Dr. Khadijah, for the answer. I hope Mr. Rafi Abiyu, is it answers your questions? Okay, thank you. All right, now we are moving on to the second questions. It's for Dr. Khadijah too. The question is from Ms. Amira Salma. The question is, are there any obstacles in using the Brunei Health app? And if yes, then what is the solution for the government in developing the app, especially for the MCH services? Thank you.
This is a very, very expensive question and a very, very interesting question. Because our Brunei Health app is only for COVID-19 related issue, and as well as for us to see our appointment, our lab tests, what are medicines. Our Brunei Health app was developed during the COVID-19 pandemic. So that's mean it is not yet expanded and it is not yet a stable app. So we do have problem. Even during the COVID-19 pandemic, we had problem with reporting our ART tests, with getting our in-order food, with having our home isolation notice. Still not a very stable application, but we time to time. So as far as the maternal and child health services is concerned, the feature is not offered yet in our Brunei Health app. So what happened with our maternal and child health service is that first we reduce the number of clinics. So meaning that we decentralize some services. Yeah, rather than having 10 clinics, we open 5 clinics. Yeah. As an example. So what I'm trying to say is we reduce the number of the service. As far as using technology, what we did was during the postnatal period, for the postnatal visit, we don't do the visit, but we instead give a phone call. unless we do the visit, unless that person seriously need those visit for us to do. Otherwise, we don't. So when I look into the questions, it says whether we provide maternal and child service through apps. We don't, but we give the feature for them to make an appointment or for them to do a video consultation, but in selective clinics. So I think they only provide about 2 or 3 clinics, not all the clinics at the moment. Thank you.
All right, thank you, Dr. Hadijah, for the answers. All right, now we're moving on to the next questions. Is for Ms. Vibhuti from Ms. Ayu Charistia. The question is how bringing healthcare to remote areas can be effective in a country where there are more remote areas than available health workers. Thank you.
Okay. So India is also one of them where there are more remote areas. So what happens, like in a village, there if there are no free healthcare centers, then I've mentioned about that ASHA and the A&M workers are there, those who are going to the other villages, and they have the doses provided to them for their health checkups, and even giving them the medicines and other nutrition. So based on that, even if there are the remote areas, so with the healthcare care providing team, then there is one body center, excuse me, that Anganwadi center is playing an important role, that is situated again in the remote areas, in which the not a frequent, but twice in a week, there is a visit of the doctors. Means doctors are visiting in these remote areas, and they can, the people can avail the services from them. They can have a checks about their own health and other issues. And these doctors stay from morning to evening in these areas, and at that time the services provided to them. And even if those health issues which are not being addressed by the doctors, then they refer it to the other doctors. In the next visit, they are told that these doctors will be again seeing you, and this way the health of the tribal health issues in the tribal belt are addressed there. Does this the questions there?
All right. Thank you, Ms. Vibhuti, for the answers. To Ms. Ayu Charistia, is it answers your questions? All right.
Tasha,
I think it's answers, yes?
Tasha, can I add in just now? I've got an answer from our head of primary healthcare in Brunei. She has provided the answer. She sent her apologies because she said she doesn't have any microphone to answer the questions. So for the provision of maternal and child health in the remote area, the recent research have shown that in Brunei we do not have any pregnant woman or any fertile age woman living in the remote area anymore at the moment. So all those living in the remote area are all those who are actually elderly and those menopausal area. So we don't have those people who are pregnant or post-pregnant living in the remote area at the moment. I've been informed by the head of primary healthcare. Thank you so much, Matron Hajar Hamlah, for giving the input. Thank you, Tasha.
All right. Thank you, Dr. Hadijah. Okay. Yeah. Okay, we have another questions. It's from the chat box. It sends from the committee. Okay, I will send the questions to the chat box too. So the question is, we know that the state of Indonesia still believes in the myths if in an area there is already a community primary health, but many mothers who give birth use child counters. The proper solution to how MEM wants the mother or family to switch to the treatment that health personnel should provide. That's the question. Maybe Miss Alia, would you like to answer?
Okay, thank you for the question. I'm just trying to figure out the question. So like the problem if the mothers do not give birth at the health workers, is that the question?
Yes, I think that is the question.
Okay. So I'm not really sure about the current data on how many pregnant women get birth at whether at the facility birth or with the traditional birth attendants. But if I'm not mistaken, there's already like the Ministry of Health guideline, like a program to incorporate the traditional birth attendants on the childbirth process. So like the traditional birth attendants, they do not help women for childbirth, for giving birth, but they were there during the childbirth, during the labor, as a doula, so to provide support, emotional support for the women, which is good. But when I did my work, my previous work in a rural area in Lombok, there's like 1-2 pregnant women who, like they visited midwives for the antenatal care, but then for the childbirth, they went to the traditional birth attendants, not giving birth at the facility. The issue probably like how women and not women like, but how the midwives like ensure like communicating with the health health workers, the midwives communicate with the women and also their families to make sure that they come back to the facility for childbirth, and also how to communicate with the traditional birth attendants itself, how to like if they do not allow the pregnant women to come to them for the childbirth, it means that the women didn't have any choice then rather than like giving birth at the health facility. So, and to communicate with the traditional birth attendants is, I think it's require not only the health workers or the head of the primary health center, but also to incorporate like the head of village or like the leader, the religious leader, or like head of the community group at that area at the village to communicate with the traditional birth attendants. How should women get a childbirth at the facility? So to ensure that the women get safe childbirth, and also to ensure that they have a positive experience during the labor and birth. I hope that answered the question.
All right. Thank you so much, Miss Alia, for answering the questions. Okay, so I think that's all for the questions we have on the Slido and from the chat box. I will give another opportunity for the participants. If you have any questions, you could use the raise hand features and ask your questions directly, or just submit it to the Slido. It's okay. I will read it out for you.
May I ask a question? If you don't
Sure.
asking a question. So I like to ask a question to Associate Professor Vibhuti. I would like actually interested in how the indigenous people access the maternity care in India. I'm aware that in Australia, the indigenous people is like a really big thing as well. Like they're trying to like incorporate the indigenous people to the maternity care system. But like I think what I found in Australia that the indigenous people, they have their own organization, like they have established organization that voicing what the community needs to the government. They also work closely with the government. I was wondering if in India that they have that kind of organization as well, or mostly what have been done in India is just still like, it's still like the health workers or the government effort to make the community to come to the health facilities, or is there any like organization from the indigenous people? Thank you.
Actually, in India, the tribal people, the indigenous people, they are now made it mandatory to when the delivery is done, then it should be in the hospital. So, when the near about the dates are coming, then what these people are doing, that they are informing that ASHA or the ANM, social workers, the health practitioners there, they are informing it to them. And from the day one, the ASHA or the Anganwadi workers, what they do, they keep a tab that who is pregnant in that village area. So with the help of that, they keep a tab and they see what is the progress is going on, what type of the health information they need, what type of the medical services they need. All these are taken care by the ASHA and the Anganwadi and the ANM workers. So also when they pay visit, to the hospitals, so already the things are arranged. Mostly that transportation is a major challenge for them to bring the pregnant ladies from their home to the hospitals, or from the hospital to the center. And there, at that time, these community and the elder people in the family, they take a decision that what should be done, what should not be done. So it all depends on the family members. First of all, they take decision on behalf of the pregnant ladies, and if they feel it convenient, or it is good for them to go for it. Otherwise there are traditional dyes also. Dyes are again the community health, means that old ladies, those who have the practices of delivering the child in their own community, so they go for help of them also, because in many of the cases the transportation become a major challenge, and they are not the vehicles are not available to the remote areas. So dyes are there, they help them into the delivery process. Hospital, it is done in the home only. Then this ASHA or the Anganwadi workers, they register their name in the hospital on behalf of them, and they get the benefits also, like some financial aid is given, their registration is done, and whatever the medical are needed during this process, they are given. Even the nutrition meals are also provided according to their affordability also. Now that little bit trend is also changing, that whatever the practices that were before establishment of the primary healthcare, they are now introducing it into their own community and their own villages. And along with that, the practices, that old method of the practices that traditional dyes used to do, now they are imparting it to the new generation also. The women who are there in the acting, like those who are interested in taking care of these health issues within their community, they are taking part. So they are also especially trained in that way. These are coming, and even the modern medicines practitioners are also encouraging them that if we are not available, then you could also take care on behalf of them. So all these practices are mixed and cross, you can say that cross roads of the tradition and the modern practices are going on in the recent time. Hope I answered your question, Professor Alia.
Awesome, thank you.
Okay.
All right, thank you, Miss Alia and Miss Vibhuti. I think we have one question from Mr. Haidar. He raised hand. Maybe you could just ask your questions directly, Mr. Haidar.
Okay, thank you for the chance. Can you all hear my voice?
Yes, you're audible.
Yeah.
Okay, thank you for the chance. Yes, from what I saw from my people around me lately people reaction about COVID changed from the first they were panic and trying to protect themselves to now people just like don't care about the virus. Maybe they were just tired with all of this situation. And but the thing was pop up in my mind is like something about psychology. The question is there psychology approach in each country? Yes, that is the question.
Yeah, if I can answer that first. So in Brunei, I agree with you, Haidar. Thank you very much for your questions. In Brunei, we begin with our when we were in our first wave, we were so panicked. Everyone was and the management was in a chaos. We changed our SOP nearly every day. And then when we moved to our second phase, we are beginning to gain that strength. And in our third wave, we were terribly overwhelmed by the increased cases due to Omicron. The daily cases, 5,000 daily, and now it's dropping to 1,000. So of course, everyone is affected psychologically. So throughout those 3 phases, what the government has done is they have provided the Talian Harapan, the line of hopes, 148 to all, which is open to all the population of Brunei, including the healthcare workers, by which they can talk out their stress. And apart from that, our government, through the Ministry of Religious Affairs, always give a Zoom program on how to cope with COVID-19. Like we were sometimes we forgot things, right? Sometimes we remember, sometimes we forgot. Because when we are so angry about COVID, we forget COVID-19 is a gift from the God, from Allah. Okay, in Islam, we need to be reminded time by time, because we were reminded by our very own Sultan last 3 weeks that we shouldn't fight COVID, because it's not something that we could fight, because it's something that our Allah has been given to us. So who are we to fight whatever Allah give to us? So he said, instead, go with the flow, with the test that God has given us, Allah has given us. So meaning that with Reda and all the Islamic aspect. So yes, I would say in Brunei, we do have psychological aspect, although it is not specific yet, but rather general. But there are dealing with those who are psychologically affected by means of, firstly, through the Talian Harapan, or the line of hopes. The secondly is through the media program on psychological support. Thirdly, through the sharing session of those who are being recovering from COVID-19, they also share their session. And fourthly, through the Islamic ways and approach to COVID-19, by which you shouldn't fight the things that is given by Allah to you, but instead you need to look into yourself. What have we done that COVID has come to our world? What bad have we done? Good that COVID-19 has bring us. It make us think. It make us more becoming more closer to Allah and all those things. Yep. I hope I have answered nice. Probably Professor Vibhuti and Alia can add in more on that. Thank you.
Yeah, that was a great answer, Dr. Kadiras. That is like same thing was happening in the India, that everybody was praying for that, how it should be this disease, the infectious disease should be gone. And most of important thing that happened during the COVID-19, that it made the people in the homes like closer to each other, in which they could even talk to each other, bring towards the closer to their friends, their relatives, and in that way they could like express their feelings, and they could even talk about their own feelings, like how they are going through, how their routine life is going on. And in that process, various people has learned various other things which they wanted to pursue as a hobby. So during the COVID times, that pursuing the hobby became one of the effective measures to loosen the mental health, it's also less among the, and when people, they like in the sense go take care within the community members. That was one of the things that was going on. But those people, those who far away from this, they are a big problem, and for their mental health issues were mostly in the challenging phase, because they could not afford to come back. They didn't have the communication issues because they can't talk to the over the phone continuously. All these things happened, but still, like through the prayers and through the all these activities, they were able to cope up with the mental health situation among in India. Yeah. Hope whether it has answered your question. Now, Professor Halia, you can take over.
Yeah, thank you, Dr. Hadiza and Associate Professor Vibhuti, and thank you for the question. Well, I'm from Indonesia as well. So as Indonesian, we know what is the condition in Indonesia, right? So like compared to Australia, where I'm working, the awareness about the mental health impact, I mean like COVID-19 impact on the mental health is not really being discussed in the social media or even in the TV or the radio. We in Indonesia, I think we still focus on doing the vaccination. We still discussing still about the COVID-19. I mean, like there's a lot of hoax about the COVID-19 transmission, something like that. But what I can share with you from my experience working in Australia, that in Australia they have already established organization for the mental health. And that's for people, got physical abuse or got, alcohol use, substance use. They can contact to that organization. During the pandemic, they expand their line. So for people who got mental health problems, issue because of the pandemic, because like Australia, especially Melbourne, they had a lot of lockdowns, that very strict lockdown. So you can contact to that hotline. And there's a lot of health promotion about mental health in Australia about as the effect of the COVID-19. So I think that's one thing that should we also adopt for Indonesia, because like it's not an easy period for all of us, especially for people who lost their job, who have reduced income because of the pandemic. It must be a very terrible situation for them and for their family. Yeah, but I think one thing that I got from the equation is like we already forgot about the COVID-19 virus, right? Because it's already like for, I don't know, like 2 years. We can't count anymore.
Count anymore. You can.
Yeah, we already almost count. So it's, I mean, like in Australia also as well. That happens in Australia. So like people, although it's strict restriction, but people still go out. But and the social media, I think it's the important one. Like people, the lecturer from any university, people working at the district like the health department, they skip, especially on Twitter, like they skip tweeting about the importance of physical distancing, wearing masks, and etc. to remind our people, because like I think that the government already like exhausted to like cover all of the COVID-19 control and prevention. And what I got is like, the Australian government already, they have like high coverage of vaccination. So they thought that, okay, that my part is done. So now it's yours to take care of yourself. But like people working at the public health keep tweeting, keep like sharing about, reminding all people like, oh, okay, we're still in the pandemic, or we're still living with the virus. So we should take care of yourself and our family. Something like that. Hope that answers your question.
is it possible to get, because my colleagues from Brunei, they are very interested with the presented by Professor Vibhuti and Dr. Alia, especially those WHO framework that you have just shown just now, Dr. Alia. So they would like, if it is possible, if the slides can be shared, probably in the form of PDF, so that they can have a look, because they couldn't read your slide just now. So they said, if it is possible for you to share the slide, that would be great.
Yes, I'm happy to share it. Maybe I share it with the organizer, and the organizer will distribute it to other attendees.
Yep. Thank you.
No worries.
Yeah, I'm also happy to share the slides, and it is help with the organizers, my slides. So.
Yeah.
Okay.
All right. Thank you so much, Dr. Khadijah, Ms. Alia, and Ms. Vibhuti for answering the questions. I hope. How about Mr. Hada? Is it answering your questions?
Yes, thanks for the question. Actually, I kind of said with the while we're trying to keep our health, but people outside just don't care about the situation. Yeah, that's the reality that what I found in the people around me. Okay, thank you for the question. That's all answer my question. Thank you.
Yeah.
All right.
Thank you.
Thank you, Mr. Haida.
Yeah. I think people are just tired, Tasha, isn't it? Like as Alia said, we are just so tired and we just lost count and we just like, okay, whatever it is, right? You know.
Yes, basically, tired of online Zoom, everything every day. I was like, if I could share my experience, if after Zoom we go to the another Zoom or Gmeet, jadi so tired. Oh my God, that's why. Mental health. Okay. Okay, since the questions from Mr. Haider marks our last questions in this Q&A session, thank you very much to all who are actively listening and asking questions. And thank you to the three of our speakers today for answering the participants' questions and sharing your knowledge to our students in the Faculty of Public Health, Universitas Erlangga. All right, ladies and gentlemen, finally, we come to the end of this lecture. I would like to say thank you to our speakers today, Dr. Khadijah Haji Abdul Mumin, and Ms. Kumari Vibhuti Nayak, and also Ms. Alia Hasbi Arini for sharing your knowledge and presenting much insightful information. And also thank you for all the audience for your active participation. And hopefully this lecture will be beneficial for everyone. Maybe before we ending the session, we would like to have a photo session with all the speakers. So I would like to request all the participants to turn on your camera and we will have a photo session. Maybe Sarda, would you like to help me to screenshot?
Okay, thank you, Tasha. I'm going to lead this photo session. For those who haven't turned on your camera, I will be waiting for 10 seconds maybe. Okay. Okay, I will start from side one. Okay, 1, 2, 3. Okay, then right. Okay, 1, 2, 3. Okay, plus 1 maybe. Okay, 1, 2, 3. Thank you, everyone. I will go back to Tasha.
Okay, thank you, Sarda, for helping me. Okay, so I think that's all for today's guest lecture. I hope everyone get a new insightful information and knowledge. And I'm Tasha as the host of this lecture. I apologize if there are any mistakes in words of action and are not pleasing to the speakers and the participants in attendance. Thank you very much. See you next time and goodbye, everyone. Thank you for coming.